All right, so I guess we're started recording. Good morning, welcome to chapter 32, Abdominal and Genitalia. Yep, injuries. Chad, you're welcome. So we're going to be talking about some trauma stuff with this. Recognition and management, little pathophys, little assessments and management. So introduction. Abdominal is the lower of the two major body cavities. So again, on Wednesday we talked about the thoracic cavity. Now we're moving on down to the abdominal cavity. It extends from the diaphragm all the way down to the pelvis. Contains organs that make up digestive, urinary, and genitourinary systems. I can't say that word. I've tried, I practiced, and I just cannot say that word. Just doesn't come out right. Injuries to the abdominal or to the abdomen that go unrecognized or untreated are leading cause of traumatic death. And so the abdomen is divided, we divide it into quadrants, right? So 4 quadrants. The diaphragm is the dividing line between the thoracic and the abdominal cavity. We have the upper right, the upper left, lower left. And it's important when we do our assessment that we understand where the quadrants are. So when we are assessing, we know what we're trying to feel and identify as the organ that might be injured or causing problems. Hollow and solid organs, a patient could lose all circulating blood volume into the peritoneal cavity without any visible external bleeding. Hollow organs are structures through which the material passes, more resilient to blunt trauma and less likely to be injured by trauma unless they are full. So that when those organs are full, they can potentially explode like a balloon. Solid organs, injury can cause severe hemorrhage. Abdominal pain from penetration or rupture has a slow onset. Abdominal pain from penetration or rupture of solid organs has, slow onset. So there's pictures of the various organs. These would be your solid organs minus the colon. That's hollow, right? Unless it's full. Right. Urinary system, solid organs are kidneys. Hollow organs are the ureters, the bladder, and the urethra. And it encompasses the reproductive system, controls the reproductive process with which life is created. Pathophysiology. General pathophysiological concerns are hemorrhage, peritonitis, and pneumoperitoneum. Injuries to hollow and solid organs can result in the spillage of their contents into the abdominal cavity, which would be bad. It's going to make people very sick. Irritation of the nerve endings occur. Pain is localized if the extent of the contamination is confined. Pain becomes generalized to the entire peritoneal cavity when it's involved. Peritonitis, which is very painful, is very intense. It's potentially life-threatening, and it's an inflammatory reaction to all that stuff leaking out. Pneumoperitoneum is a rupture of a hollow organ, perforated peptic ulcer, or recent abdominal surgery or rupture of an abscess. So this is where you possibly can get, they nick the bowel when they're doing abdominal surgery. Compression injuries are caused by a poorly placed lap belt. With this, you can see this is in the upper abdomen area where the lap belt is coming across. Probably somebody who is just slunched down in the seat, or it could be somebody who is quite large, and because of their size, they modify the lap belt. Deceleration injuries occur when a person or the vehicle strikes a large immovable mass. So obviously it's their body's in motion and they come to a sudden stop. Shearing, because of that sudden deceleration, shearing may cause tears from the ligamentum teres hepatis. Signs and symptoms with this is going to be pain, tachycardia, so they're going to have a rapid heart rate, hypotension, cool, pale, moist skin. So they're going to show signs of shock. Crepitus in the lower rib areas. You'd have the Kerr sign, pain that follows that angle from the lateral part of the hip to the midline of the groin can be a result of damage to the kidneys or ureters. So here's the picture. It talks about that lap belt, kind of the belts being in the wrong spot. Obviously, higher risk in small children, short people. Somebody pregnant women may not be wearing the belt in the right spot as well. So that would be a cause of extra concern when you're assessing that individual. There's some signs, some bruising signs. They could have voluntary or involuntary guarding. Bruises in the right upper quadrant, left upper quadrant, or flank might suggest an injury of the liver, spleen, or kidney. Again, so remember where your organs are within those quadrants as you're assessing. And bruises around the umbilicus, it's called the Cullen sign, are predictive of significant internal abdominal bleeding. So that right picture right there, that's the Cullen sign. Make sure also when you're doing on these MVCs, we're doing a good check of the interior of the vehicle. You're looking underneath the airbag for signs of damage to the steering wheel. So you're looking for deformity of the steering wheel. You're looking for dash deformity, anything that could indicate the mechanism of injury of what you should suspect is wrong with that patient. So you're trying to look for all that stuff. And again, if like I mentioned the other day, is we have the ability to take pictures with our tablets. So in some of these more critical crashes, it would be wise to take a moment to take a picture, have somebody take a picture with the tablet so that we can show the doctor and the nurse, the surgeon maybe, to show them what we saw on scene, give them a better appreciation of what might be going on with this patient. Open abdominal injuries consist of things like gunshot wounds, stab wounds, so stab. Bowel could include the small bowel, colon, liver, vascular structures, the diaphragm. All these obviously can be involved, and it's going to be hard for us to figure out exactly what is involved. Obviously, this patient is going to end up needing surgery. Yeah. Understand the mechanism of, say, maybe the entrance wounds, and understand what is what's in that path of that entrance wound. And again, if you see an entrance wound for possible gunshot, always expect to have an exit wound. Just expect it. So when you don't have it, then you're still looking, right? So, but try to just expect having an exit wound. Evisceration, it's icky. I have yet to experience this on a call, but it's an open abdominal injury where you have an opening in the skin and the abdominal cavity is starting, the organs in the abdominal cavity are starting to come out. Signs and symptoms are going to be signs of bleeding and puncture wounds, rapid heart rate, evidence of shock, distended abdomen, and a rapid and severe bleeding. Injuries to specific structures. So this is where we're going to get into the different areas of the abdomen. So diaphragm is the abdominal organ which may push upward into the thoracic cavity. So remember we talked about this the other day where if they have a herniation, this could push up into the thoracic cavity and cause pressure on the lungs and even to the heart. Patients exhibit dyspnea, so difficulty breathing, feeling short of breath, abdominal respiratory sounds, and an abdomen which is sunken. So what was that sign? Who paid attention on Wednesday? Scaphoid. Scaphoid, right? Scaphoid abdomen. So it's going to be that sunken abdomen, and it's going to have that presentation of almost like a malnutritioned body, all right? Causes and signs and symptoms of ventilatory compromise. These patients they're gonna feel very anxious. They're gonna feel very anxious, obviously because they can't breathe. They're gonna have that, like I said, the shortness of breath, especially if they're in a supine position. Kidneys, if they rupture, can cause pain on inspiration in the abdomen and into the flank. Injuries rarely occur in isolation. Blunt renal trauma results when the kidney becomes compressed against the lower ribs or even the lumbar spine. It is the most commonly injured organ of the genitourinary system. Okay, so that's the most common. So that will probably come up on a test. What is the most common injury of that system? Penetrating renal trauma is more likely to be associated with injury to the liver, lung, and spleen. Suspect kidney damage when there's abrasions, lacerations, contusions, or hematoma to the flank region. So you're going to get that bruise, that blood clotting in the flank region. Penetrating wound in that region below the rib cage and above the hip or the upper abdomen. So remember, this is in the retroperitoneal space. So you're typically going to see that in the lower back flank area. Fractures on either side of the lower rib cage or of the lower thoracic and upper lumbar vertebrae can also cause a puncture or rupture of the kidney. Here we're going to talk about liver and spleen. Livers can be penetrated or ruptured and may lead to signs of shock. The liver is what the function of the liver is. You have a lot of red blood going through there. It's helping filter out some of that blood. Must be suspected in patients who have right-sided chest trauma as well as abdominal trauma. So again, we're going to be seeing that it's partially covered by that lower rib cage. And when somebody were to take a deep breath, you can actually, if it's even engorged, it might even show signs of swelling up underneath that lower right rib cage. With the liver being punctured, they can actually have referred pain up into their right shoulder. Spleen is potential for rupture and much higher, and is much higher if the spleen is enlarged with mononucleosis. So somebody who's experiencing mono. Or as a result of the chronic fatigue of mono. There's some complications for people that have experienced that later on in life. Large amounts of blood spill into the peritoneum when the spleen is ruptured, and suspect spleen lacerations from fractures of the 9th and 10th ribs on the left side. So again, it's those rib fractures that are going to help lead you to suspect there could be some spleen rupture. Pancreas presents with vague upper and mid-abdominal pain that can radiate all the way into the back. May lead to peritoneal irritation hours after the injury. So it doesn't is not necessarily onset. It could actually become worse. Intestine and stomach occurs from penetrating trauma and blunt trauma. Ruptures of the stomach causes rapid burning epigastric pain. They're going to get rigidity, and they could even have rebound tenderness, which is similar to what you're looking for with appendicitis. With intestines and stomach, pain may present as back pain as well, and not necessarily abdominal pain. Blunt trauma to the abdominal wall commonly causes injury to the duodenum. Contamination of the retroperitoneum with duodenal contents may produce abdominal pain and fever. Abdominal pain, nausea, vomiting may develop, and obviously with this patient, the more they vomit, the worse that pain is going to get. That's just going to irritate the abdomen. Most injuries of the stomach result from penetrating trauma. Trauma to the abdomen may cause injury to the small bowel, stomach, large intestine. And we talked about the rupture causes some of those signs. The burning, epigastric pain, rigidity, rebound tenderness. Okay. Urinary bladder. Blunt trauma to the lower abdomen or pelvis can cause urinary bladder rupture. Remember, this is going to be more the case if they have a full bladder, is they have a higher probability of a rupture, and it's due to that blunt trauma or sudden deceleration. Urine may spill into the abdominal cavity, and what's going to be the issue with that? And it's right. The urine is highly acidic, and they're going to get very sick, right? So it should suspect in any patient with trauma to the lower abdomen or pelvis. Urine may spill into any part of the abdominal cavity, leading to intraperitoneal, extraperitoneal, or retroperitoneal rupture. Genitalia. Testicular torsion occurs as a result of trauma. I've been on a couple of these, and it looks miserable, absolutely miserable. That patient actually has pain from the scrotum all the way up into the abdomen. I mean, most of us can relate at some point getting kicked or hit of something with a ball, foot, hand, somebody playing around, getting hit in the testicles. It hurts, right? Now, these testicle torsion is when the inside your sac, everything is starting to twist up. I think the last one I was on, there was no trauma related to that, and it was kind of just a weird, things moved and got twisted up. Injuries to the testicle, it's an injury to the testicle or scrotal sac. It's actually very serious. They have a small amount of time to get that fixed. Penis injuries result from blunt or penetrating trauma, sexual behavior, or self-mutilation, and can actually get a fractured penis, which may result from blunt or penetrating trauma. Fractured penis may occur when an erect penis is accidentally impacted against the partner's pubic symphysis or bent too far via self-manipulation. Penetrating trauma is most often resulting from gunshot wounds. So injuries with the testicles and scrotum can lead to a loss of fertility, and that's the major concern of that. Female genitalia. Uterus, ovaries, and fallopian tubes are rarely damaged because they are small, fairly small, deep in the pelvis, and well protected by the pelvic bones. Penetrating trauma may result penetrating trauma to the reproductive organs may result from stabbing to the lower pelvis or even gunshot wounds. As pregnancy progresses, the uterus enlarges substantially and rises out of the pelvis, becoming vulnerable to penetrating and blunt injuries. So you're going to expect signs of shock with pregnant patients. Just expect those signs. External injuries include the soft tissue injuries, and you truly need to determine if there's a potential for that female to be pregnant if you have some type of abdominal injuries. Vascular injuries are a result of blunt trauma to the vascular structures in the intraperitoneal space. often masked by other injuries. Significance of these injuries depends on how many vessels were injured and the length of time that passed since the injury occurred. So your assessment findings are going to be can be different depending on whether the bleeding is contained or there is an active hemorrhage occurring. Abdominal aortic aneurysm is present and it may worsen. So aortic aneurysm, that AAA, you might hear it referred to. Rectal bleeding is a common complaint. Seems like every time it's either we get a call for a hemorrhage or a bleed, it's either a rectal bleed or a nosebleed. So with rectal bleeding, though, could be caused by a sexual assault, rectal foreign bodies, hemorrhoids, colitis, ulcers of the digestive tract. So it could be a number of different things. So any questions so far with the different structures, the different organs in the abdomen? Online? Anybody? Questions? Okay. Awesome. So patient assessment is going to be huge, right? So we have to do a thorough and complete patient assessment. We got to do an ongoing assessment. We got to expose what is needed and then cover all that stuff that's exposed, right? It's important to uncover it, but at the same time, we need to make sure that we recover it back up because we need to protect their body heat. It's part of treating the signs and symptoms of shock. You need to do a scene size up. Look for indicators of the MOI. Again, looking at the vehicles, what in that vehicle is damaged or has signs of distortion that could lead me to a higher suspicion of that mechanism of injury. Inspect the penetrating wounds. Consider early spinal precautions. Many of patients may avoid discussing genitalia injuries. So again, for a lot of patients, that can be embarrassing, and you may not know exactly what's going on. They can be very vague with their descriptions and just say, I have abdominal pain. I've got abdominal pain. And you do your assessment, you do a thorough assessment, you get to them to the hospital, and then you find out that they have something else going on, either in their rectal region or their genitalia. So, and that's not necessarily on us. It's just because the patient is they're shy. They're embarrassed. They don't want to share that news with everybody. So we should not prevent that from us doing a good, thorough assessment, though. Evaluate the ABCs. Make sure you do ABCDEs. So ABCDE. So the books are using that now. So airway, breathing, circulation, disabilities, and then what does the E stand for? Huh? Rusty? What's E stand for? Exam?
There's no
ABCDE?
oh.
That's that thing that's a backwards 3. What is it, Max? Online? Expose. Right. Thank you. So there was another comment. Maybe it was not pertinent. Right. Thank you, Ryan. Matt, not so much, and Ryan. All right. Let me get back on my screen here. Follow X, A, B, C, D, E. So, primary survey. Another letter. Remember to keep the airway clear of vomitus. So trying to clear that vomit. Positioning is important. Having that patient sit upright or in a semi-Fowler's position. Or if they have to be supine, make sure you try to roll them, tilt them up on a little bit of a side, put some pillows or blankets underneath one side of the backboard to help tilt, to help protect some of that airway in case they do vomit. Assess for adequate breathing, constantly evaluate circulation, pulse, and skin signs. Perform an early assessment of the abdomen looking for decap BTLS. Again, checking all 4 quadrants. Now, if they're complaining of, say, lower left quadrant pain, that'll probably be the last quadrant that I actually check. I'm going to start in the upper and then go from the lower, and that left lower being the last one that I check. Early assessment of the abdomen. Perform a rapid full body scan of the patient. You need to identify any life-threatening problems while you're doing your scan and stop and treat those immediately. Obviously, because if you don't treat those immediate life threats, you're not going to be able to continue. That patient's going to crump on you. Examine the abdomen closely and even look for hemoperitoneum. It's important again to get a good history taking when this patient is conscious, if this patient is conscious, because should their condition get worse, at least you have that information before they go unconscious. So trying to get that OPQRST to assess history of present illness. If it's just simply an illness, this is where it's important to find out that OPQRST, truly. If it's trauma related, we may obviously modify the OPQRST for that trauma. Getting that sample history statement so you understand the signs and symptoms, their allergies, medications, pertinent medical history, last oral intake. Ask whether the patient has experienced any nausea, vomiting, diarrhea, because all that is going to be can be related to the abdomen. But remember that can be related to other conditions as well. So it can be related to cardiac issues or even your head traumas. Ask about the appearance of any bowel movements or urinary output. If this patient's got sudden onset of severe sharp abdominal pain, it's important to find out when their last bowel movement was. Maybe you find out that during their sample, you find out that they're taking hydrocodones for chronic pain, and they haven't been taking the stool softeners that is prescribed. So now they've possibly got a blockage. You're also going to be following that up with your looking for that decap BTLS of the quadrants, and you might find a rigidity in, say, that left side of the abdomen in that colon area where they might be blocked up. Urine output. It's important about urine output, especially when it's related back to possible kidney stones. Or even as it relates to possible UTI, if they have any blood in their urine or if they have any pain during urination. So again, do a good thorough assessment when you're doing your history taking. Secondary assessment, you need to obtain, obviously, and monitor vital signs. We do this. This is nothing new. Focus on isolated injuries and perform a physical exam. So again, you might still do a head to toe in the beginning, but then go back and focus on that location of complaint. Assessing decap BTLS, hematuria. Assess the patient's pain on a scale of 1 to 10, 10 being the worst pain. 10 is I stepped on a Lego barefooted in the middle of the night. 10 could be, for somebody that has had kids, 10 is childbirth or whatever. Try to give that patient something that they can relate to as a possible 10. And if they can't, again, we have the tablets with the faces, the little happy, sad, crying faces. And they say they're a 10, yet they're on their phone. Show them the picture of crocodile tears. It's like, this is a 10. You're on your phone. So what you're telling me is not a 10. Okay? With this secondary assessment, it would be a good idea even to listen for abdominal sounds. Use your stethoscope. Listen for abdominal sounds. You should hear some gurgling within about 5 seconds of you putting the stethoscope to the belly. It doesn't happen immediately, but it could. But listen for a good 5 seconds on each quadrant of the abdomen. Listen for those abdominal sounds, especially if they say they haven't pooped in a few days. I mean, it's just going to help with your overall assessment and your documentation and report back over to the doctor. So when you do listen, you are listening for those little gurgling, like fluid, air bubbles going through the abdomen. That's what you should hear. And we talked about that on Wednesday. If you hear that up in the chest cavity and they're having the difficulty breathing, that could be that perforated or ruptured diaphragm and it's leaking into the chest. So again, caution, something to think about. Identifying trends in pain and vital signs. You want to communicate the MOI and the injuries. Communicate with that patient, recap their story so you have a good grasp of what is going on. You want to be able to recap that story over to the doctor and to the nurses when you do your patient care transfer. Make sure you document all your findings, obviously, and if you have any concerns or questions with what you did find, contact medical control for assistance. And we have that ability, whether it's by phone or by radio, contact medical control. I've done it a few times in the years I've been here because something just didn't make sense. I wasn't sure about, I was pretty sure about what I'd found, but I just wanted some clarification. I kind of want to put that onus back on the doctor for that continued care because they're the ones that are going to be seeing them here in about 5-10 minutes when I drop them off. So I just want to make sure I'm giving that patient the proper care. With the vital signs, reassess, reassess, reassess. You can't stress that enough. Obviously, you know, the sick patient, we all know this, every 5 minutes at least for sick patients, 10 to 15 for stable patients, and looking for your trending. Trending, by definition, is going to be 3 or more. 2 vital signs is not trending. Okay, 2 vital signs is not trending. 3 or more vital signs is trending, and you have a better grasp of what is going on with that patient. So any questions on primary, secondary, and reassessment? No, no, no? Beautiful. Online, I just expect you to start typing if you have questions. We'll pick it up. Let's see here. All right. So assessment and management of the specific injuries. A lot of these are going to be the same and nothing groundbreaking. Nothing groundbreaking here. Spinal immobilization and spinal motion restrictions, obviously with blunt force trauma, when there's concerns of spinal injury based on your mechanism of injury. High flow oxygen, and we always talk about high flow oxygen in the book, but obviously that can be modified, and anything from, the book says high flow, so obviously when it comes to testing and natural history, anytime you're giving oxygen, you're giving high flow. But in reality, we're maybe at least giving them a nasal cannula at 4 liters a minute. Okay, so that's reality. Reassessing, especially if this patient is sick and they're on that way to maybe getting tubed, putting a nasal cannula on them and cranking it up because we're looking at possibly setting them up for passive oxygenation while we intubate. Okay, so you're going to be helping set up that medic for success if you get that in place. Unstable pelvis in our system, based on our protocols, we're going to use pelvic binder, right? So we have our SAM splint, the pelvic binder, SAM pelvic binder. If you don't have one for whatever reason, it didn't get restocked for whatever reason, we can bind that pelvis with a sheet and just be cautious. That patient is going to get some type of a relief when you do bind it appropriately. Some patients may not benefit from, if you suspect a pelvic fracture, you got to understand what part of that pelvis is possibly fractured, because I have experienced one patient in my time where we decided, based on the injury, we did not stabilize, we didn't bind the pelvis, but we padded around the pelvis for support, and that ended up being the proper treatment for her. Rapid transport to the closest facility. Obviously, at this time, we only have the one. We got Kootenai. We're going to be transporting there. Provide emotional and psychological support en route. And I can't stress that enough. There's a lot of times when we get so caught up trying to maybe manage an injury and try to get the tablet going, or if the monitor is not working appropriately, or whatever the case may be, and we forget to actually just talk to our patient. Provide that psychological, that emotional support to that patient. Reassure them that they're going to be okay, especially if they're having anxiety. The best thing that we can do for that patient when they're experiencing anxiety is talk to them. Talk to them and try to calm them down. Help them and coach them with breathing. Try to relax them. Closed and blunt abdominal injuries. Patient may have one or some combination of those injuries. Focus on ABCs if diaphragm is injured or even suspected of injury. Monitor for signs of shock. Keep that patient warm. So some of the combinations: severe bruises of the abdominal wall, laceration of the liver and spleen, rupture of the intestine or gallbladder or the stomach, tears of the mesentery, which would be bad, rupture of the kidneys or avulsion of the kidneys from their supporting structures, ruptures of the urinary bladder, severe intra-abdominal hemorrhage, peritoneal irritation and inflammation in response to the rupture of those hollow organs. So all those are some of those combination of things that can go wrong. All right. Good luck. Open and penetrating abdominal injuries, you need to assume that the object has penetrated the peritoneum and entered into the abdominal cavity. Anytime you see an opening into the abdomen, just assume that it is the worst case scenario. Stabilize the penetrating object if it is still in them, and initiate 2 18-gauge IV lines. Now, again, if this patient is in shock, you may not be able to get those IV, that large bore IV. Get the largest that you can adequately administer, and consider doing an IO, right? There's plenty of awesome pictures online about abdominal penetrations and items that have gone into somebody and ways of stabilizing. Abdominal evisceration. Again, I haven't seen this yet. I kind of want to, just because the pictures look cool. Although treatment for this is kind of crazy, right? You don't want to push down on the patient's abdomen. Pushing down on the patient's abdomen would be like pushing down around a zit to pop it. More stuff is going to come out, which would be bad. Perform only a visual assessment. Don't poke at it. Never try to replace an organ that is protruding from the abdomen. You don't want to push it back in. It needs to be cleaned. Cover it with a sterile gauze compress. So we're just going to cover it with sterile gauze. It should be wet sterile gauze. Yeah. Moist. So use some sterile water and onto a abdominal pad and cover it up. Try to keep it as clean as possible. Obviously, we need to try to control some bleeding, but do the best you can. Now, here's the thing. So the book says cover it with a sterile gauze compress moistened with sterile saline solution, and then secure them with a dry sterile dressing. How are you going to do that? So it could be, I guess, maybe using the inside of the plastic of a saline bag. Yeah. Sterile. Try to keep it as sterile as possible. Kidneys, signs of shock if the injury is associated with significant blood loss. Blood in the urine is to be kind of to be expected. Maybe it's present. Treat shock and associated injuries, provide prompt transport to the hospital. For the bladder, suspect a possible injury to the urinary bladder if you see blood in the urethral opening, or the physical signs of trauma to the lower abdomen, pelvis, and perineum. Transport again, and treats any injuries or treat for shock. Genitalia, make the patient comfortable. Good Lord. Try to control bleeding. Never move or manipulate impaled objects. Identify and take avulsed parts to the hospital with the patient. Now, it seems like I heard a story recently of somebody in one of our local departments holding pressure on a male genitalia at some point recently. Good for them. Good patient care. Never apply a constricting device to the penis to control bleeding. You don't want to wrap it with a tourniquet. Don't do that. No tourniquets for that. Manage blood loss priority in amputation of the shaft. Suspect testicular torsion when there was direct trauma to the testicles. No attempt to remove any tight objects around the penis, testicles, or both should be made in the field. I've actually seen that once where a young child, for whatever reason, did a self-manipulation with string and wrapped it around the shaft, and it got wrapped, and because of the swelling, it ended up binding, and there was no getting it off in the field, and it had to be done at the hospital. I was an 8-year-old. So these type of things can happen in different types of people, different age patients that you wouldn't even suspect. Just weird. Female genitalia could have lacerations, abrasions, and avulsions. Should be treated with moist, sterile compresses. Remember, we don't want to place anything up inside. Don't want to pack it down there. Use local pressure to control bleeding, and a diaper-type bandage to avoid dressings in place, or to hold dressings in place. So we have chucks that we can lay down, obviously, with any of these types of injuries. Anytime that we have a lot of gross hemorrhage and we're trying to control bleeding, whether it's in the genitalia, the abdomen, chest, neck, head, think about actually putting down chucks. Make sure you think about that in order to help control some of that. Not really control the bleeding, but it's providing less mess for our cleanup afterwards, right? So just something to think about. Leaving any foreign bodies in place, stabilize them with bandages. Bleeding can usually be controlled by local compresses. Carefully evaluate contusions and blunt injuries. Again, ABCs, continue to monitor. Urgency of the need for transport will be determined associated with injuries, the amount of hemorrhage, and the presence of shock. Contusions and other blunt injuries may require careful in-hospital evaluation. If you believe, and here's an important piece, if you believe your patient has been sexually assaulted, do not examine the genitalia unless obvious bleeding requires you to apply a dressing. And in those cases, you want to try to deliver everything to the hospital. And on that note, actually, anytime there is any type of violence in the field, or even a potential fatality, you need to transport everything, all their clothes. Always transport their clothes. We had the incident with the fatality drowning in the river a couple months ago, or last month, whenever. The lady drove into the river. Some of her clothes was actually left on scene. She got stripped a little bit on scene, a jacket off, I believe. You know, our typical care is we try to remove wet clothing and then try to keep them warm, right? So some of her clothing was removed in the field prior to her getting into the ambulance. I transported her in. We stripped, trauma naked, took all her wet clothes off, some of those clothes actually got thrown away at the hospital by mistake. That is a bad thing. So anytime you have sexual assault, like I said, trauma or fatalities, make sure that you transport all that stuff. The investigators need that stuff for their investigation. Not just the, like I said, not just the coroner. The coroner is going to need that stuff, but also like the county investigators or city investigators when they're putting that case together, because they have to write a case on it. All that stuff has to be documented. So awesome. Any other questions about abdominal injuries, trauma, nature of illness, exam, online? You're so quiet. I can't hear you. All right. We're going to shut this one down and try to figure out how to